Welcome everyone to the Acts 2 workshop, Advances in Reducing Risk for Dementia, Medication and Behavioral Approaches. I'm Dr. Rob Glukoff, servant leader of the Acts 2 project and professor, Florida State University College of Medicine. In case you are unfamiliar with the term Acts 2, it stands for African American Alzheimer's Caregiver Training and Support Project 2. Folks, I am very excited about the prospects of tonight's workshop. This workshop offers valuable information about the latest developments in medication-based and behavioral methods for lowering the risk of dementia. Our first presenter, Dr. Angela Hill, will focus on the different roles of disease-modifying and memory-enhancing drug treatments for Alzheimer's disease and other dementias. She also will describe the benefits of consulting with community pharmacists to obtain consultation for medication management. Our second presenter, Dr. Lisa Fox, will share her journey in participating in a memory disorder drug trial and in advocating for early detection, early treatment, and research participation. Our third presenter, Tamika Norton-Brown, will provide information about culturally responsive skills training and support for family caregivers of older adults with dementia, as well as dementia care resources. Before I introduce this evening's presenters, I want to recognize our partners who've contributed both resources and guidance in the development of the Acts 2 Dementia Caregiver Workshop Series. Acts 2's primary collaborators are the African Methodist Episcopal Church 11th Episcopal District, the Florida Progressive Missionary and Educational Baptist Convention, the Florida State Primitive Baptist Convention, the Florida General Baptist Convention, Florida Church in God in Christ, and the Florida State University College of Medicine. Turning now to tonight's presenters, we have three inspiring speakers. Our first presenter, Dr. Angela Hill, is Professor and Associate Dean of Clinical Affairs at the University of South Florida, USF, at the Nahok College of Pharmacy. She received her doctorate in pharmacy from Florida A&M University and completed a residency in neurology at the Neuroscience Foundation. She is a licensed consultant pharmacist specializing in mental health, neurological disorders, and geriatrics. Dr. Hill has provided consulting services to the Florida Department of Elder Affairs and the USF Neuroscience Bird Alzheimer's Institute, as well as specialty clinics in memory disorders and related dementias and Parkinson's disease. Her research focuses on Alzheimer's disease and related dementias, including studies on biomarkers, vaccines, and disease-modifying therapies. Last, she is director of WeCare, the Community Engagement and Research Recruitment arm of the USF College of Pharmacy. Our second presenter, Dr. Lisa Fox, received her bachelor's degree in nursing at Notre Dame University. She worked as a pediatric intensive care unit nurse in Atlanta, Georgia, for several years. Lisa later decided to obtain her doctoral degree in dental surgery at the University of Texas Health Science Center in Houston and completed a pediatric residency at the same institution. She subsequently moved to Denver, Colorado, where she was owner of a multi-office pediatric dental practice. In addition to managing the dental practice, Lisa served as chairperson of the Colorado Dental Board for 5 years. In 2022, Lisa was diagnosed with mild cognitive impairment from posterior cortical atrophy. After the diagnosis, Lisa became her own self advocate by enrolling in several long term studies and a Leqembi clinical trial. She is actively involved in efforts to promote early detection and early treatment and participation in dementia related research. Last, Tamika Norton Brown is coordinator of the ACTS2 project and has served in the area of survey development and evaluation for approximately 25 years. Tamika has been a caregiver for her dear aunt and uncle with dementia and has a passion for helping others. She's been a great source of encouragement and support to literally hundreds of family caregivers of older adults with dementia across Florida. Mrs. Norton Brown is also a strong leader by example in her church community. Folks, during the workshop, I encourage you to share questions to be answered after each presentation using the text message function of Facebook Live. We also will have a 20-minute question and answer period following the last presentation. And now we have Dr. Angela Hill.
Awesome. Good evening. It's such a pleasure to be here this evening and participate in this wonderful program. Thank you for that introduction, Dr. Glukoff. And it's always so great to be able to work with you and your team. So I get the exciting opportunity to actually, if I can figure out how to make it present. There it is. To talk to you about advances in reducing risk for dementia from a medication perspective. And what I hope to do in my time with you is talk about where we are with diagnostics and how that is impacting our ability to decide on which course of therapy is appropriate. And we have disease modifying therapies now, and we're still using our cognitive supporting aids. So we'll look back at them. We'll also talk a little bit about how pharmacists like myself can help caregivers and others living with the disease to manage it so we don't have any problems. And then there's a lot of other resources that I want to also mention that are available to you to kind of help you navigate this disease. So, in the last 20, almost 8 years now, as I've been working with Alzheimer's patients in various clinics and initiatives, we've learned a lot. We've learned that since Dr. Carter and Dr. Alzheimer himself discovered the biomarkers in unfortunately cadavers, we now understand their role. We used to not be so sure whether or not the biological markers, the neurofibrillary tangles, the amyloid plaques, were the result of the disease or if the disease caused them. And now we understand a little bit more in regards to what they do, what they mean, and their pathological processes. So now we know that we see evidence of these proteins as early as 20 to 30 years in some cases before symptoms actually occur. And that is a very valuable time. So it's actually like the disease almost is hibernating, but also causing damage. And so what we've appreciated is that the amyloid plaque development and neurofibrillary tangles actually precede the onset of abnormal growth of tau and other proteins that are very crucial. And by the time we start seeing tau being either accumulated or more present in the brain, unfortunately, that's around the time when symptoms occur, which typically has us somewhere in the 50s to 60 age risk, unless people have a familial history. So this is really important because now we understand a little bit also about those that might be predisposed to the disease because of genetic factors and those whom we might know whether or not they're going to get it when they're 65 and older or whether or not they're going to get it younger. So one of the most popular genetic nuances that we've appreciated has been work around the ApoE gene. And these particular alleles or formations of this genetic process, now we understand really what they do. So we think that the ApoE2 allele is a little bit more protective. The ApoE3 may not necessarily influence a lot of what we're seeing with the disease manifestation, but the ApoE4 allele actually may be increasing the risk for dementia, but later on. We also know that there are some proteins that kind of precede ApoE, and we call them precursors to amyloid processes, and they show up on certain genes like 21 or chromosome 21, chromosome 14, and or 1. And the interesting thing about this is that some of these chromosomal abnormalities are also noted in our mentally retarded populations, etc. So this is really significant. Now, we typically in clinical practice don't necessarily go testing for these particular genes unless there is some family history to warrant that. But what we do now know and understand is that certainly those who are at risk for or have a strong familial history, sometimes we'll see those abnormalities with the precursor genes, but then those that are more prone to late onset gene, we might see ApoE alleles. But what I do also want to mention is that ApoE, unfortunately, isn't the only genetic correlation. And you can tell by this picture that there are numerous others, some of which we think have a lot more clinical significance for some of the populations that we see burdened more with the disease, like African Americans and or Hispanics. But appreciating all of this now is kind of giving us some clues as to what direction we need to take in terms of treatment. So usually we categorize treatment of Alzheimer's disease in one of three buckets. Either it's symptomatic, where we're responding after the diseases have started presenting them, and the symptoms have started presenting themselves, or we're trying to do something in the neighborhood of what could be perceived as prevention, but actually is slowing down the progression of the accumulation of these biomarkers, the progression of the accumulation or the development of these abnormal proteins. And then last but not least, sometimes we treat patients for some of the other problems, or what I call collateral problems that occur as the disease progresses. And so we'll talk a little bit about what that looks like. But why don't we start off with our symptomatic therapies, or our cognitive, I like to refer to them now as cognitive supporting agents. And the reason I do that is because they can't correct the damage that's been done. Again, most times these therapies are instituted when patients have started exhibiting symptoms. And so unfortunately, although we have a lot of clinics and things that are now designed to actually help us identify people who are at risk for dementia, unfortunately, people aren't optimizing that and being seen early enough for these drugs to really slow the progress down in a significant factor. However, they're really very valuable, though, I think, for quality of life. And excitingly, they can actually be used with some of our newer therapies. So you might be familiar with drugs like the Donepezil or Aricept, even memantine. We have galantamine and Razidine and Exelon. But what you might see is sometimes combinations where Donepezil, Razidine, or galantamine or ribostigmine can be used with Namenda, or you might see them used alone. And fortunately, we can interchange with them. So if you take one and you have side effects or don't seem to respond, we can switch out all of them. But the first three can be used with memantine, and that kind of gives us this combination approach. And so we do actually, or should be, prescribing them based on the stage of the disease that patients are in. And oftentimes people, unfortunately, are a little closer to moderate stage of the disease before they actually start treatment. And so that, unfortunately, hinders our ability to really make a big impact. And what these drugs primarily do is act on conserving one of the primary chemicals called acetylcholine that is actually involved in our memory processes. Subsequently, people endure, unfortunately, a lot of gastric side effects like nausea and vomiting, diarrhea, constipation, and some other things that we have to monitor as we use them. But what we do appreciate is that they do again save us sometimes 18, 24 months of the disease actually progressing. And so that can actually be valuable. That could be the difference of someone being institutionalized in a nursing home or not. Our disease modifying therapies, however, give us a little bit more run. So I do want to talk about them. Now, in contrast to our symptomatic therapies, our disease modifying therapies actually are all administered by infusion. We have two on the market right now, lecanemab and donanemab, and they actually came after our first one, aducanumab, that came on the market during the pandemic. That drug was both exciting, we were excited about it, but it also was a lot of controversy behind it. So you won't hear us talk about it anymore because unfortunately it was removed from the market. However, some of the reasons it was removed from the market are things that still are ever present and concerning with the two agents, but nonetheless, we're still excited about having these drugs, and we'll talk about them. So the way they work is actually by preventing the accumulation, the development, and the growth, and even the sticking together or aggregation of these the beta amyloid that we think is present in the brain. And so they work a little differently. They're not all exactly alike, but ultimately they target beta amyloid. We do know because beta amyloid precedes the development of tau, this is actually very, very beneficial for us to be able to modify the accumulation of amyloid, because that's what actually slows down the disease and why we refer to them as disease modifying. Now, everybody can't qualify for them because they do inherently, unfortunately, cause some challenges for us. And so we don't want to use them in people who are older than 85 because we haven't done any studies in people that are that old living with dementia. And they have to be as early in the disease process as possible so that we get the better outcome. So individuals that have mild cognitive impairment or early dementia are those who are ideal for these treatments. And so I can't emphasize enough how important it is that we get baseline evaluation, that we're aware of our family history, et cetera, because if you're going to be able to use these drugs, we need to be early in the disease. The other things is that for patients who've had things like mini strokes or a full-fledged stroke, or any problems where they've been bleeding in the brain, they may or may not be the ideal candidate for these therapies. And we have to be able to prove that they have amyloid actually in the brain, and we use a PET scan to do that. So with me saying all of that, some of the primary concerns is that once these drugs get in the brain, because they're sweeping out or affecting the growth of amyloid, the brain reacts to that because amyloid's natural physiological responsibility is to protect the brain from viruses and other illnesses. And so when we start modifying the availability of amyloid, sometimes the brain may swell, sometimes the brain may bleed, and we see it on the PET scan, and we refer to it as ARIA, or amyloid-related imaging abnormalities. And so this has been one of the major concerns, and we noticed this back when aducanumab was on the market. And so individuals who've had hemorrhagic strokes, more than likely are going to have issues. People are not excited by the fact that we have to give these drugs intravenously because this pipes up the cost. And then the most discouraging thing about this class of drugs, and the reason why aducanumab got removed from the market, is because even though we're sweeping the amyloid out or getting rid of it, unfortunately, that doesn't always equate to the clinical benefit that we want to actually see. So the FDA has put a couple things in place. One, they want us to make sure patients meet the requirements to be on the therapy. They also, though, have to do the genetic testing because we've learned that individuals that have that ApoE4 abnormality are the ones that are at a greater risk for having these issues with ARIA. The other things that's been concerning has been the cost and whether or not we could get coverage. We're working on that, and I'm going to talk a little bit more about what the costs particularly are. But again, I just want to clarify again that ARIA can be either the brain swelling or the brain bleeding. And so this has been both a scare and a concern. And some patients, do experience this and some not. And the way we know we're having issues, most times patients are asymptomatic, but sometimes they can have things that just tell us the brain is having some challenges, from headaches to dizziness to visual changes. Nausea, vomiting, difficulty walking probably are the most common symptoms. Sometimes it looks like they're having a mini stroke. And so that's concerning. And then rarely we've seen, in some cases, things like seizures or prolonged seizures like status epilepticus. So this, again, is why we have to be mindful of these kind of therapies. And so these precautions that we take in working up a patient to see if they're appropriate for it, if they've got underlying bleeding disorders, or these genetic malformations, they've had cancer in the last 3 years, or had a stroke or seizures in the last year, or any kind of contraindications that won't allow us to use an MRI to let us know that there's some imaging abnormalities, we may or may not necessarily want to use them in these patients. Even things like substance abuse, vitamin B12 deficiency, and or depression can actually be concerning. And so it's a lot of work to use these drugs. So the difference between the two that we have on the market is lecanemab is something that has to be infused every 2 weeks. In comparison, donanemab is done on a monthly basis. And actually, donanemab is much more potent than lecanemab. And so what we do end up seeing is a little bit more likelihood of ARIA occurring with that drug. We do have differences in terms of how frequently we'll go back and do the imaging to check for the presence of ARIA. And I have it indicated here, but what you'll see is that baseline and every couple of weeks or several weeks will be required for a period of time. It's not necessarily a lifetime of having to go under MRIs. But again, if a person has contraindications, this can be challenging. There are other side effects besides ARIA that can occur. We've had patients with atrial fibrillation, some gastric issues, things like cough, changes in blood pressure, etc. So this is why monitoring is so important, and making sure that we have issues. And some of the landmark trials that were done on lecanemab and donanemab, actually this showed that they're both more effective against placebo when studied for an 18-month period. However, and we do see, as I showed in the previous slide, that in some cases we have about 15-20% of patients that actually might experience this ARIA. And so we have to be mindful of that. So the Clarity AD trial is what actually landed lecanemab early consideration, and fast track approval by the FDA. And then the Trailblazer ALZ-2 study actually was beneficial in helping us appreciate donanemab. And so what we have seen, though, is truly a decline in the progression of disease. That was evident in both studies, which is valuable. And again, we're, comparing it. Now, with donanemab, they actually looked at the load of tau. And that becomes really important because, remember, that's the abnormal protein that's a little bit more prevalent when patients actually have ongoing symptoms. So some of the things that I do behind the scenes is work with clinicians to make sure, one, they can pay for it. We have access to centers. We're still trying to learn how long they have to actually use it. And then patients have to agree to be in a registry, because we're doing post market approval monitoring. And so all of that MRI information is actually being looked at so that we can make sure that we're refining treatment standards for patients to have the best outcomes possible. I'm also looking and making sure that concomitant medications won't cause problems. So it's allowable for us to use donepezil, razidine, galantamine, etc., but they have to to be on them at least 3 months before we actually start the disease modifying therapies. When they're already on a blood thinning kind of agent, we have to wait and make sure they're stabilized for at least a month. And we're still trying to figure out whether or not we can use them in patients that may have myasthenia gravis or multiple sclerosis, because these are biologic drugs. They're referred to as monoclonal antibodies, and we don't want the immune system to have an inappropriate reaction. So some of the other concerns as to why aducanumab was removed is it hit the market costing over $50,000. It was quickly adjusted and reduced down to $26,000, but that's still a lot. Lecanemab is right in there at the same point. Donanemab is a little bit more expensive, and so this again is why this has been controversial. And part of the controversy is because when we compare it to what it costs us to treat a patient with donepezil, $840 is a lot more palatable than $26,000. And then when we look at clinical outcome, it looks as if our symptomatic therapies may actually outperform the disease modifying therapies. So we still need to answer questions like, are we getting it to the right patients early enough for these drugs to make a difference? So as I kind of wind down, I want to also spend a few minutes talking about what you probably saw in the news in the last a couple of months, and that is the breakthrough of us having now a blood test that can actually help us determine whether or not patients are appropriate for some of these therapies. So I mentioned with the disease modifying therapies that we have to use a PET scan to tell us the amyloid is there. We have to use MRIs so that we can pick up on ARIA, and a lot of that is adding to the cost of the therapy. And in some cases, or heretofore, we would use lumbar punctures or get cerebral spinal fluid to be able to look for those biomarkers. And now having a blood test, we find that clinically we can do the same thing that the PET scan was doing for us, as well as not have people go through a painful lumbar puncture for us to identify these abnormal proteins. So what is measured basically is they're looking at amyloid beta and or the ratio of some of the different congeners. That's all that means. And then we look to see what the levels are to tell us whether or not we have Alzheimer's disease. Now, this biomarker or blood biomarker research actually started back 2011 by different groups, and we've been looking at biomarkers for years. So we're really excited to have something on the market now. So we have several companies, I'm not sure what happened to my slide, that are doing the test, but I'm going to skip to the one that is FDA approved. But what I will tell you is that Quest, LabCorp, Eli Lilly, Roche Diagnostics, several other companies, CN2. We have multiple groups that have been looking at blood tests, because like I said, this isn't necessarily new research, but the one by a Japanese company that was FDA approved is referred to as the LumaPulse G, and I won't repeat all the other letters that go along with it, but what it does is it looks at the ratio between p-tau or phosphorylated tau and beta amyloid, and then it tells us whether or not, again, that patient would be at risk or appropriate for these disease modifying therapies. So again, this is something everybody can't use. The patient has to be at least 55, and they should be able to definitely be in the early stages of the disease. And so again, being able to measure these things and give a numerical value has certainly been very beneficial, and it is as clinically comparable to what a lumbar puncture was actually doing. And so that's very significant, and they've actually done some research trials. Now, the downside, the insurance companies are not paying for it just yet. So the Alzheimer's Association and other groups are lobbying for consideration of that. But we're talking a minimum of $400 to at most $1,500 in some cases. One of the companies does have a patient assistance program, but again, this is something that we have to actually work on. And so, again, as we are modifying how we're approaching this is exciting, exciting, exciting news. Now, what are we doing for people who have the disease and are developing symptoms and may not qualify for therapies or be too far gone to get these disease modifying therapies and they've exhausted or are on our symptomatic therapies? Well, unfortunately, what we see a lot of times is behavioral problems, and they may manifest as hallucinations, delusions, agitation, apathy, depression, all of these things. But what we're finding now is that drug companies are spending a little time coming up with therapies that are most concerning for caregivers. For example, we have an antipsychotic called brexpiprazole, or Rexulti is the brand name, and it's used typically in schizophrenic patients. However, it's made a meaningful difference in patients that have dementia and are agitated. And so, again, we're excited about this because this is the first FDA approved therapy. Prior to Rexulti coming on the market, we were using antipsychotics oftentimes and things like Xanax and Ativan to try to control these, but it was not FDA approved. So we're really, really excited about that. The other area that's interesting is that we're able to also better address sleep problems in patients that have Alzheimer's disease, because we see a lot of disruption in sleep, and this can also be both annoying as well as unfortunate for the caregivers. And so you'll see drugs like Belsomra that have been on the market now for several years, almost approaching 10 years, that have FDA approval to actually address the sleep disturbances in patients that may have dementia. So these are exciting breakthroughs. And what we're trying to really advocate is that individuals will get tested as early as possible so that we have a broader range of treatment choices to be able to help them. It helps us in regards to quality of life as well as the cost of managing the disease. So what does it mean for you? Well, you have access to pharmacists like myself who can actually help you navigate, medication use, whether or not they're on therapy, or if they're taking other medications. We can actually do a barrage of things like help you know what time to take them, work with the doctors in terms of making sure the dose is correct. We're minimizing drug interactions. We can help you identify when there's problems to pay for the medications, and certainly advise you on things like herbals, over-the-counter products, etc. So I really encourage you to incorporate or get to know your pharmacist so we can best help you. And there are a lot of other resources out there. The memory disorder clinics are all across the state of Florida. We have 17 actually that will actually help us get to a point where we can diagnose people early enough so that they can get access to a lot of these therapies that I talked to tonight. If not, start with your family practitioner. But if you're in the Tampa area, we have a lot of things going on at the Neuroscience Institute, drug studies as well, that will actually allow you to be able to get access to some of these costly drugs free of cost, free of charge, but also getting this top-notch care and monitoring so that, again, we can improve quality of life. So I think I kind of went over my time, and I do apologize, but I will certainly and gladly entertain any questions anyone has. But again, this is an exciting time for us because we've got advances in diagnostics with the blood test. We have advances in treatment as it relates to our disease modifying therapies. And then we also can now address some of the problem behaviors by using some of our drugs like Rexulti and or Belsomra. So thank you again, Dr. Glukoff and the X2 team, and I'll stop there.
That was an outstanding presentation, and you did not go over the time frame. That was just so meaty, and I'm a vegetarian. So that was there was just so much information that you provided. I have that was extremely useful.
Mhm.
Just a question, one or two questions. What is your sense for the extent of persons who are have cognitive decline?
Mhm.
To what extent are they being worked up diagnostically
Mhm.
for mild cognitive impairment
Mm.
by primary care physicians?
Well, we don't have enough of that going on. Unfortunately, cognitive workups are not a part of what we consider a vital sign. It's not an annual screening that's required, but it should be. Just the other day, we were talking about how women in perimenopause and menopause, that is a unique time to catch some of this stuff. And now that we have a blood test, right, that would be a really cool way for us to do some early testing. But I think what happens is the family practitioner oftentimes, when it comes to areas of the brain, unless the patient brings it up or the caregiver brings it up or family member, they don't necessarily go down that path. And so we have to, as self advocates, think if you have family history, like I've had grandparents on both sides of my family. So that might mean I might be one of those that has that genetic wiring. And so I need to also be as responsible and engaged in reminding them that, hey, can we get a baseline testing? Because there are opportunities out there. And when we talk about trials, there are trials out there right now where you don't have to necessarily have a drug. They'll just do all of that testing just so we can learn more about the appropriateness of using these therapies. So I don't think the family practitioners think enough about cognitive screening, and most times they react only if asked.
Thank you so much. I have multiple other questions, but I'm going to hold back until the 20-minute Q&A, question and answer period at the end, and now bring on Dr. Lisa Fox. Welcome, Dr. Fox. We are so pleased to have you here and look forward to hearing the narrative of your walk with mild cognitive impairment.
Well, I appreciate you inviting me, and Dr. Hill's was amazing. Had a lot of really good information that everybody needs to know. But a little bit about me. I am a pediatric dentist. I was a nurse before that. I'm retired now. And in 2022, I was diagnosed with mild cognitive impairment. And that diagnosis was not easy to get. My first symptom was that I couldn't read, which doesn't make any sense to anybody when you tell them that. What do you mean you can't read? You have a doctorate degree. You can't read. And I went to ophthalmologist, optometrist, my physicians. I can't read like I should be able to read. And I happen to have a neurologist for my migraine headaches that I've had for many years, and he's helped me with my migraine headaches for years. And he said, "What do you mean you can't read?" I said, "Well, I can read and I can do your tests and I can do all your games and all that stuff, but it's not the same." And he said, "You know what? That sounds like a brain problem, not an eye problem." And that started the journey. But it was years before anybody would listen to me about something's wrong. And I want to emphasize to anybody who gets to hear this that if something feels wrong, then it's wrong. You got to chase it down. And, but before I was diagnosed with MCI, after I was diagnosed with MCI, it was a long journey to get there. So once my neurologist sent me to the next neurologist who was actually going to take care of me, it was 6 months before I could get in. 6 months. So we waited 6 months. I didn't have a diagnosis yet, and we had to wait 6 months. The time came to go to the neurologist who was going to do the testing, and indeed, I was diagnosed with mild cognitive impairment as a result of posterior cortical atrophy, a pretty rare kind of Alzheimer's, which affects the vision part of your brain. And that made a lot of sense once somebody unraveled that. Again, it took 6 months to get into the neurologist to get a diagnosis. And at the time, there was no medication. I mean, there was no drug trials for it or anything. So we went through the drug trial list, and we called every single one in the country. I didn't qualify for one. It wasn't enough for another. There was a whole lot of a lot of them never called me back. But we did. So we got on a plane and we went to Houston and said, I want to be in your lead trial, your lead study. And that got me into the neurologist there in Houston. That was before I saw my neurologist in Denver, because I was waiting for that, 6 months, and I wanted to do something in between. So we went and we did the lead study, and we went back and kept doing it. Once I got, once the person who was going to take care of me in Denver, it turns out she actually is a PCA specialist. There's only a few in the country, and it was a miracle because not a lot of neurologists know anything about PCA at all. And we then moved to Florida, and this is before any medication besides Aricept. That's all we had. All I had was Aricept. So we moved to Florida, and another 6 to 8 months before I could see the neurologist. And I know, and there's just not enough. There's not enough people to diagnose this disease. And we were able to get into some trials right away. And this is all before Leqembi, which is the one that Algeham that I'm doing, that I have. And as soon as the drug was approved, we were able to get out of the study or get out of the trial. But once it was on the market, we still didn't get it for 8 months. So this is several years have accumulated since I knew something was wrong. And so it was a frustrating time. All of these practitioners are amazing people, and they're just overworked. So that was the journey that I had to start with. And just a side note, my dad was diagnosed with early onset Alzheimer's in his 50s, early 50s, 52, and he died at 62. He was in the original Aricept trial, but again, and no one ever asked me that. Nobody ever asked me if in any kind of screening and any kind of anything, no one has ever asked that. When I offered that up to the neurologists. So I think that, again, overworked, not enough people to help with screenings. I lost my train of thought. Go figure. I can't see it. So one of the things that is profound is advocacy for early detection and lifestyle and making sure, we have mammograms, we have our blood pressure taken every place you go. And nobody ever asks people at their PCP anywhere. At their PCP, we ask them if they fell since you've been here. We ask older people, have they had a fall? But we don't ask the harder questions. And I know, again, PCPs are overworked and have too many patients, and but I think that it's incredibly important that we address the risk assessment, and the blood test isn't really going to right now be widespread because it's incredibly expensive. So, and nobody wants to talk about it. So, the other takeaway is Alzheimer's is not just an old person's disease. This starts long before, and I think we've made great strides in the getting ready to be able to support all these people. And it's not hopeless. I've been taking Leqembi for, it's my 37th. I had my 37th infusion last week. I personally have had 0 side effects at all. And it's been an amazing journey. And I feel very blessed that the people who I got to eventually steered me in the right direction and has made this journey so much easier. So I really just want everyone to hear that if something isn't right, it isn't right, and don't stop advocating for yourself. And that's all I really have to say.
Sorry, I have to unmute.
That
That does help, doesn't it? At any rate, we do have an affirmation for you, Dr. Fox, from dear Whitney. Gianna, thank you for sharing your story. And I do think that that's a very important affirmation, because it's clear to me, and I'm sure it's clear to others, that you have dedicated yourself to sharing the narrative with to others, and I would imagine in a variety of settings, and that's it. The story needs to be told, and
we don't want it to be a secret.
Yeah, I have a quickie question for you. I don't know if there's a quickie answer, but I have a quickie question. What are your thoughts for those who do not have access to experts in low prevalence conditions such as your condition, which with posterior cortical atrophy? Of course, there are others who have low frequency conditions that are associated with cognitive decline. How do those individuals ensure that if they don't have access to experts, how can they work with their neurologist to ensure that they get the most effective intervention?
That's you're right. I don't know that there's really a great answer for that. One of them is just go to the next person and try and beg, and I was just really super persistent. And I was in a metro area in a perfectly, and people look at me, and the physicians look at me and say, I don't know what you're talking about. And I don't know. I think the hiding and the veil and secrecy around Alzheimer's disease is starting to break open. And I think that's going to make a big difference when people are talking about it. But I also believe very strongly in having, and I know that the neurologists that treat Alzheimer's are developing these, that questionnaire that's 5 questions, and the PCP can do it, the nurse practitioner can do it, and those are going to be important to get the people to the right place.
Thank
But
you
the
so
rare type of disease, it's just a rare disease.
We have a comment from to-be Dr. Sarah McCracken, who's at the University of South Florida College of Medicine. She says, "Thank you for sharing, Dr. Fox. I'm disheartened by your experience. I'm a current med student starting my neurology rotation and have never heard of PCA."
Yeah.
So,
I mean, I would love to
thank
have
you, Sarah.
everyone understand. Yeah.
Thank you so much. We have other questions for you, Dr. Fox, that we're going to bring to the table during our panel discussion later on. But now we're going to have Tamika Norton-Brown, Acts 2 Project Coordinator.
Good evening, everyone. What I'm going to do is provide information on our Acts 2 project and the services that we provide. Next slide, please. Okay. For our Acts 2 program, let me also preface by saying that as I describe the type of services that we have, I will make a distinction that there are some services that are available for distressed African American caregivers of older adults with dementia across Florida. And then there are some services that we will provide to any person, regardless of race, regardless of location. Let me also state that to qualify for the 12 session program, which I'll give a bit more detail about in a moment, you need to be a relative caregiver, and we loosely define relative, spend at least 6 hours a week in caregiving, and be experiencing distress from your caregiving duties. We are a faith-based program, but we're also ecumenical. So you hear me talk a lot about faith sharing and prayer. We are faith-based, which means that those elements have been woven into our actual program, but we are also ecumenical. So not professing a particular faith or be questioning will not prevent us from providing services to you. So we offer 3 major types of services. The first is our faith-integrated group skills training and support for distressed African American caregivers of older adults with dementia across Florida. And that's our 12-session program that I mentioned a moment ago. We have dementia awareness presentations and workshops that we will conduct at faith, community, and elder care venues, as well as, like we're here tonight, we have a very active social and print media that reaches across Florida and the U.S. We also do individual telephone-based problem solving and information and referral consultations, and that's to all dementia caregivers and other stakeholders across Florida and the U.S. Next slide, please. For our Acts 2 12-session program, and as I stated before, African American caregiver, relative, loosely defined, and I can always say you can be related by blood or related by love, spending 6 hours a week in your caregiving duties and experiencing distress. The Acts 2 program includes 7 group skills building, so 3 caregivers in a group, and 5 individual sessions. All of the sessions are delivered weekly over our toll-free telephone by trained lay pastoral care facilitators. You'll hear me talk about our lay pastoral care facilitators. Those are simply lay persons, so non-pastors, from the community or the faith community who have self-identified or been nominated by their judicatory leader, and we train them to be able to deliver the 12-session program. In those individual sessions with the facilitator, they focus on goal setting and problem solving to address those concerns that have been identified by the caregivers. Most caregivers come into our program with 2 or 3 things that they want to work on, and they get that one-on-one time with that facilitator to focus on coming up with some strategies to help them achieve those goals. Next slide, please. The contents of our building modules. Our program has 6 major components. The first is the overview of the basic characteristics of the dementias. So every caregiver who comes into our program will get an overview. We call that Dementia 101. There is relaxation training that's combined with calming prayer and or meditation. We want to break the myth that relaxing is just getting in your favorite chair, kicking off your shoes, and you're relaxed. When in actuality, there's an entire process of having mind, body, and spirit enter into the state of relaxation. So we train our caregivers on how to relax. We work with them on effective thinking about the challenges of caregiving coupled with scripture, just being able to change the way that they're thinking about their caregiving situation. Next slide, please. We also have my favorite module, but it's the one I've yet to master. I call it the me time module, or emotional well-being. It's just building in pleasant daily activities as a guard against emotional distress. So being able to negotiate time to be able to take a walk or listen to your favorite type of music. We also work with our caregivers on communicating effectively, not only with the care partner with dementia, but with family and health professionals. And then lastly, developing those effective problem-solving skills through personal goal setting. Next slide. When we talk about dementia awareness training, we will deliver both in-person and virtual dementia awareness training to family caregivers and other interested parties. Some of the more common topics that we cover is the basic information about the characteristic and stages of dementia. We cover risk factors for Alzheimer's disease and related conditions, and then strategies for preventing or delaying the onset of dementia. Next slide, please. For our individual problem-solving consultation, 1 or 2 problem-solving sessions are delivered over toll-free telephone by our Acts 2 staff members. And let me also mention that each and every service that I have mentioned that we provide in Acts 2 are absolutely free, and they're all done over the phone. That caregiver will prioritize 1 or 2 goals, and we work with them in developing an action plan. So some of the example problems that we work with caregivers on is they're having difficulties with bathing and hygiene for their loved one. They may be having challenges getting their loved one to eat, and then difficulty getting help from family members. Next slide, please. For our information and referral consultation, once again, absolutely free, done over our toll-free telephone by our Acts 2 staff members. 1 or 2 sessions where we will let them prioritize their goals, and we work with them on developing an action plan. Some of the more common I&R concerns that we work with people on are they want to identify affordable caregiving services. They want to find culturally responsive adult daycare centers, and then they want to locate effective estate planning assistance. Next slide, please. We have included some information on dementia care resources. There is the Florida Department of Elder Affairs, the Alzheimer's Association, the Alzheimer's Foundation of America. There's the Elder Helpline, the Elder Care Locator, the Alzheimer's Disease Education and Referral Center. Next slide, please. Interested caregivers can learn more about Acts 2 by telephone, by email, or through the web. You can contact us at toll-free 1-866-778-2724. Once again, that's 1-866-778-2724. 2724. My local to Tallahassee cell phone number is 850-274-4945. And the toll-free number also rolls to my cell phone number. My email address, tnnorton@fsu.edu. You can also reach us here on our Facebook page, Acts 2 Caregiver Project. Send a message. We do respond, and we will reach out. And what we're now going to do is do a tour of our website. And our website address is www.acts2project.org. If you will click on Program of Services. On our website and under Program of Services, you will find information regarding the services that we offer, our 12-session skills building support program, what to expect, what to learn. It also has information about our information and referral and brief problem-solving consultations. If you will go back up and click on Caregiver Resources. On our Caregiver Resources page, there is the video archive of all of the Facebook Lives that we have done over the past several years. We do record. This live will post to our Facebook page, but it will also post to our website. So you can come to the website and go back and look at any of the video recordings as well. We also have things like prayers and readings. We have fact sheets on basics of dementia, caregiver well-being, a ton of information that is useful to caregivers. We've tried to create it as a place where you can come to that one page and get information on different topics. If you will go back up to Donate, please. If you're interested in learning more about how the Acts 2 project is funded, and or if you're interested in donating to our Acts 2 project, you can come to our donate page and find that information there. All of the services that we do provide in Acts 2 are absolutely free for caregivers to participate. So if one is interested in donating, you can find the information here. And if you will go back up and click on Contact Us. If you have a question, or if you would just like to know more information about Acts 2, you can come to our website, fill out the Contact Us form. That will route to my email, and I will respond, or a member of the team will make sure that we respond back to you. We hope that the information that's been provided has been useful. What we are now going to do is we are going to do a panel discussion. So if you will bring back up the participants, please.
Thank you, Tamika. The resources that you discussed were extremely helpful. I know that the services that Acts 2 provides are all free of charge, and that they are, as you indicated, culturally responsive, and that every effort is made to tailor the work we do with caregivers to their faith traditions and their family values. So thank you so much. And now we're going to switch to the panel discussion. Esperance, do you have any affirmations or questions for the group? Okay, I'm going to go ahead then. I know that you're collecting them now. I'm going to go ahead and ask a couple of questions to each of you. Dr. Hill, we'll start with you. A basic question, very basic question. What are the differences between tau and beta amyloid, their characteristics?
Mhm.
And they're both proteins, but what are their differences? And what are the impacts that each of those in accumulation
Mhm.
have on the functioning of neurons, of nerve cells in the brain?
Okay. Well, as I mentioned, amyloid is actually, we know that its physiological role really is to protect the brain. When it grows abnormally or accumulates, then it sets off processes that can harm the brain, and it's like it hits a switch to then start tau to start growing. Now, tau unfortunately contributes a lot to neuronal damage. So what we know is that in Alzheimer's disease, the brain shrinks, and that's evidence of neurons dying. And we credit that to, one, the fact that the neurons are tangling up, or we get neurofibrillary tangles, and then they start dying off, and that's why that brain shrinks. So as Dr. Fox was sharing, the posterior part of her brain was starting to shrink, and then that affects function. So, excuse me, tau, again, is the one that we tie the most. The neurofibrillary tangles and tau actually are things that we attach the most to the brain shrinkage. But ultimately, whichever part of the brain is shrinking or dying, then we know that's going to affect our ability to remember whatever category of that memory. So it might be, our vision might be affected, or our spatial orientation, our ability to make decisions, all of that. So that's the ultimate consequence of having these excessive proteins and stuff there. Now, beta amyloid is also tied to inflammation as well. And so we do know when we have anything foreign in the body, the immune system will naturally help us fight it off. Well, in the brain, it's encapsulated in the skull. And so the only thing it can really do is swell, for us. And that's how we know. And that swelling isn't always good, because then that sets off other processes that then affect function of the brain. So that probably is a quick way to kind of describe the importance of why we need to control the growth of these abnormal proteins.
Just a clarification, for amyloid, those plaques, are you suggesting that leads to the development of tangles, or is that an independent process?
Those are two different processes.
Okay.
Yeah. So one is happening inside the cell and one is happening outside of the cell, right? But the beta amyloid sets off what happens with tau. And once it gets phosphorylated, then that's when we start having problems. And that's why the biomarker research is so important, because we can actually start measuring this stuff, right? To see how it's accumulating in the brain. So I hope that helps. Thank you.
Thank you.
Mm-hmm.
Appreciate you doing a little bit of review on the basics of it. I think there's a lot there to understand. Question for you, Dr. Fox. It's a sort of a basic question. When you were going through the process of seeking out disease-modifying treatment with Leqembi, were there challenges that you faced because you had posterior cortical atrophy rather than a traditional Alzheimer's diagnosis?
No. We were able to get the Leqembi as quickly as anyone else, jumping through the hoops of the insurance company and just getting the whole system set up, no, they don't.
That's good news.
Yeah, nobody even asked.
Dr. Hill, a comment from you on that is that when in terms of being a candidate for Leqembi, either a trial or the medication, what are the causes of decline that are associated with the development, with the choice to be a candidate for the medication?
So basically, for the disease modifying therapies, they have to be younger than 85.
Right.
We certainly look at not necessarily the type of dementia, although we know Alzheimer's disease is typically, the most common one, but there's no contraindication if they have Lewy bodies disease, et cetera. It's just that they have to have the presence of amyloid in the brain. There are other biomarkers that are associated with some of the other dementias like Lewy body. We have a Lewy body, right, that we actually can see, that can be measured in the body. But in this case, they have to have the presence of amyloid. They have to be younger than 85. And then we definitely have to have the ability to monitor them by an MRI to be able to see the impact or development of ARIA, right? Because that's an outstanding concern there. And then, on the blood test, they can be much younger, but when it comes to the therapies, that's right now the criterion. And then we don't say some of those precautionary things, like if they have, cancer and or substance abuse use, then we look at how long, and then we also look at concomitant medications to determine again what risk they're going to be at, more particularly for the ARIA than anything. And the ARIA H, where they're bleeding, is our major concern also.
Yeah, just a follow-up question on the bleeding. You talked about APOE4 as a potential factor that may increase risk of amyloid-related abnormalities. Am I getting that right?
Yes, sir.
Okay. How does that actually occur?
So I think, okay, so let me back up to say that situation where we have the ApoE4 allele, when we have two of those alleles, that person is at a greater risk for late onset disease, right? But when we talk about, why is it they're at greater risk for ARIA, that's a result of the studies. So when I was referring to the Clarity AD study, right, that was one of the hallmark studies that we looked at, and we noticed there was a trend genetically that showed that that population of people that had that allele issue were at a greater risk for ARIA. And so all of this, any of these life-threatening side effects, you want to be able to say this person should not, use the therapy. Now, we'll also say that we have looked at ApoE from a racial and ethnic angle as well, and we noticed that it is a little bit more prevalent in the Caucasian population compared to other ethnic groups. Doesn't mean other ethnic groups won't have ARIA as an issue, but I think some of why that becomes a greater risk factor is because those are that's the majority population. Oftentimes one participates in clinical trials a little bit more, right? So then we have the likelihood of stumbling upon more of this ApoE4, because that's the population that is participating a little bit more. So that's all the more reason too why we encourage more people to participate, so we can be able to say what's going to happen if Ms. Norton or myself take this. Will ApoE be a connection, or will some of those other genetic formations, because we do know that there's a few of those other ones, like I talked about presenilin, and some of those other precursor genes. Well, we tie those a little bit more to the high likelihood of things like high blood pressure or the other metabolic disorders like diabetes and high cholesterol. And when you look at the groups that tend to have a higher risk of Alzheimer's disease, they also have a higher risk of those chronic disorders as well. So the earlier we can test people, the better. The more that we get people to participate in clinical trials, we'll be better able to answer some of these questions. But I think it starts back with the population that was participating the most in those trials were Caucasian, and that's the group that happens to have the highest frequency of the ApoE4 allele issue.
Thank you. Uh, Shifting to you, Tamika Norton-Brown, can't resist that, of course. What is your experience in working with caregivers about their involvement with community pharmacists, in particular, the benefits that they've derived from consulting with those pharmacists about dementia related or MCI medication?
Over the last couple of years, it has gotten better because, as we know more, we're able to guide others in things that they can do. A lot of caregivers were unaware that they could actually do a consultation with the pharmacist to ask all of the questions. So as we're learning more, we're now able to say, yes, you can absolutely ask for a consultation. Yes, you can absolutely say, mom has X, this, mom is taking this, and this. The doctor just prescribed X, Y, and Z for memory. What will there be any type of contradiction in that? So as we have learned more and as we kind of build this network of resources and know how to direct people, it has gotten better. For the ones that I have spoken to who have actually taken the time to schedule those consultations to ask those questions, they come back feeling that they have a little bit better sense of control of what's going on, because before that it was just all fear, because it was the fear of the unknown and then they weren't sure. But once they're able to kind of equip themselves with more information, they go forward feeling a little bit more confident, and some have even gone back to the physicians once they've met with the pharmacist and said, hey, mom is doing XYZ, you've not prescribed this, does she really need to have this? So it's kind of giving them the power. They've taken the power back in the situation and now know how to move forward, what questions to ask, and know that their pharmacist can be a resource that they can go back to and get information as things change.
Thank you.
Can I add something to that?
Of course.
Mrs. Norton-Brown, could you please emphasize and to everyone on this program that individuals that are over 65 are actually eligible for a comprehensive medication evaluation once a year. And so they can get that now. There are pharmacists in the community setting, and then there's some of us that are in, other clinical and specialty clinics, but I would just encourage them to make sure that they capitalize on that. And it can happen like even in their annual wellness visits, that may be a good time to ask, although medication typically isn't a focus there. Usually it's about health prevention, but certainly that can be something where asking, going back to Dr. Glucow's question earlier about primary care doctors, certainly encouraging them and reminding them that they're due an annual medication, evaluation at least once a year.
Thank you.
Dr. Fox, I have another question for you, and then we'll shift to final thoughts, just to honor the time that you have all contributed to this and our audience's commitment to a lengthy workshop. Here's the question. Have you accessed support from PCA support specific groups as part of your journey?
Yes, we have.
And could you share that with us a little bit, just your takeaway? I know that's not a 5-minute conversation.
No, but we found that the patients are not there. It's usually the caregivers.
Yeah.
So
I was wondering from the group, a quickie question. Would you, Dr. Fox, and you, Dr. Hill, feel comfortable receiving questions from members of the audience? I believe that there's at least 1 or 2 folks who are interested in communicating with you.
Mhm.
Would you feel comfortable talking to them?
Yeah.
of course.
Yes.
Okay.
Definitely. Mhm.
Dr. Fox, we actually have received a request. There you go. It's B. Jean Williams. Thank you, B.G. Williams. How may I contact Dr. Fox? I'm dealing with a similar situation, which she described as pertaining to her.
That's interesting. Yeah, I'd be happy to.
Okay. Would you want us to get the contact information for you from B. Jean Williams before the end of the program and give you that information?
Sure, that'd be great.
Okay. B. Jean, please put it in the chat, or if you wish, you could send it to tnnorton at fsu.edu. T is in Tom, N is in Nancy, Norton, N-O-R, N with Nancy, O-R-T-O-N is in Nancy, at FSU, Florida State University.edu. That's T.N. Norton at FSU. Thank you. And Dr. Hill, we can do the same for you if we get a request.
Yes.
Okay, folks. Final thoughts. Your final thought for the evening.
Well, mine is early diagnosis, early diagnosis, early diagnosis. And then we have broader treatment opportunities. Prevention is key. And so that will, and capitalize on your pharmacists. We're the most accessible healthcare professional, and oftentimes the last health professional that's seen before you go home with poison. So let us help you understand more about what to expect from medications. But yeah, just want to say that. Thank you.
Thank you, Dr. Angela Hill. Dr. Fox?
Just mostly efficacy so that we can just get the word out, and we just want to open the closed doors of Alzheimer's to not being a something to be afraid of, and early diagnosis. And if something seems wrong, don't stop digging until you get it.
Thank you, Dr. Fox. Tamika Norton-Brown?
I think my final thought would be to educate yourself, equip yourself with as much knowledge as you can, and then that will cause you to empower yourself to make sure that you are taking the best care of yourself and your loved ones.
Thank you, Tamika Norton-Brown. I'm going to be somewhat greedy here. I have 2 final thoughts. One is I want to honor those persons with mild cognitive impairment, those with dementia. My wife is a person with dementia. She has probable Alzheimer's disease. She is my teacher. I have learned more from her about me personally and about effective caregiving than I have in anything that I've done over the past 25 years working in this area. So I just want to make a very strong statement in honoring the strengths and wisdom of persons with memory disorders. That's number one, final thought. Number two, our next workshop, next Acts 2 workshop, will focus on negotiating stressful caregiving situations through the use of creative problem solving. That workshop is scheduled for Thursday, August 28th on Facebook Live, 7 to 8:30 p.m. Eastern Time. Please join us for this workshop. You'll be hearing more about that workshop over the next few weeks. Want to thank everyone aboard, the panel, and our very thoughtful and very contributory audience in making this workshop a very inspiring and informative experience. Thank you, Whitney, Gianna. We're glad you enjoyed the presentation. BJ Williams, thank you for indicating that each of the panelists are worthy of meriting high levels of thanks, and that you're glad to have been able to listen to the workshop. We have a North Point resident. Thank you all for this help this evening. Glad that you're with us, North Point resident. Antoinette J., thank you. Glad that you enjoyed the workshop. Joy Herring, sorry, Joy. I didn't mean to say Jay. Great information. Thanks, everyone. Great affirmation. Thank you. And we appreciate your participation. Well, thank